Good afternoon. I am Dr. Rajendra Prasad. Currently, I am working as the Director Medical Education and Professor and Head, Department of Pulmonary Medicine, ERA's LUCKNOW Medical College and Hospital, Lucknow. I have been former Director, PATEL Chest Institute, Delhi, and I have been also former Director, UP Rural Institute of Medical Sciences, SAIFAI, which is Medical University today. I spent my 40 years in KGMC, that is KG Medical University, and I was head of Department of Pulmonary Medicine for a very long time. Now today, we are talking about drug-resistant TB. Where are we? Means how much is the problem of drug-resistant TB? Today people talk much about drug-resistant TB. My objective would be today to present you that what is drug-resistant TB, what is the current status of drug-resistant TB, what are the causes of drug-resistant TB, and finally, certain take-home messages. When I talk about TB, I usually say that TB is 100% curable disease. In last 4 decades, whatever I have experienced by treating thousands and thousands of patients of tuberculosis, I can say with very robust voice that TB is really 100% curable, provided the treatment is enough, good treatment is provided to the patient, and patient is compliant, means patient take those medicine. If these two parameters are met, to my understanding, TB is 100% curable. But unfortunately, 1.5 million deaths was reported by tuberculosis in 2014 globally. Around 2.5 lakh people died in India itself in 2014. If I am going to speak you for about 30 to 35 minutes, about 25 to 30 people will die within this time. It really surprises me, it must surprise you also, why there is so much of death. Main cause of death is the poor treatment, so subsequently the development of drug-resistant TB. And what is drug-resistant TB? Drug-resistant TB can be defined as a case of tuberculosis, usually pulmonary, excreting bacilli resistant to one or more anti-TB drugs. Now, it may be extrapulmonary TB. It is not always it is pulmonary TB. Drug resistance again can be divided into two types, primary drug resistance and acquired drug resistance. Primary drug resistance means drug resistance in a patient who has either taken no treatment or else has taken treatment up to 4 weeks of time. Acquired drug resistance means retreatment group, means drug resistance in patients who have already received treatment for more than 4 weeks. Now, there are many types of drug resistance described today. We have monoresistance. When we talk of monoresistance, means resistance to first-line anti-TB drugs. Most common drug resistance described is isoniazid. There could be polydrug resistance, resistance to more than one drug other than MDR TB, multi-drug resistant TB. Example is, suppose somebody is resistant to INH and streptomycin both INH and ethambutol or any primary line of drug except multi-drug resistant TB. Then comes multi-drug resistant TB, which is defined as resistance to at least isoniazid and rifampicin plus minus other anti-TB drug. After MDR TB, we have extensively drug resistance, means XDR TB. XDR TB is resistance to any fluoroquinolone and at least one of the 3 second line injectables like capreomycin, kanamycin and amikacin in addition to MDR. So, what is XDR TB? It is extension of MDR TB. MDR TB means resistance to INH and rifampicin plus resistance to any of the fluoroquinolones and any of the second line injectables. Now, lately with the advent of molecular diagnostics for the drug resistance, we have come with another term, what we call is as rifampicin resistance, or in short we call it RR, and it is resistance to rifampicin detected using phenotypic or genotypic method with or without resistance to other anti-TB drugs. It includes any resistance to rifampicin in form of monoresistance, in form of polyresistance and in form of MDR or XDR TB. Now, lately literature is coming up with another variety of drug resistance, what we call is as total drug resistance or also known as extreme drug resistance or complete drug resistance, although the WHO has yet not defined this term, but what it means that resistance to all available anti-TB drugs. So, this is how what type of a drug resistance you can come across. Now, after that what I am going to tell you that how much is the prevalence of drug resistance. As I started, the first drug resistance is a mono drug resistance or polydrug resistance. Now, mono and polydrug resistance, the studies are not done very globally, but whatever studies are available. Now, most common drug resistance, as I said earlier, as primary drug resistance is concerned, about the mono drug resistance in form of isoniazid resistance, this is mostly, if you talk of globally, it is in tune of 5 to 15%. If you talk of monostreptomycin resistance, it also ranges around 5 to 7% globally. When we talk of acquired drug resistance, means when person has taken some treatment, when we talk of isoniazid monoresistance, it may range from very low to very high, depending upon that how much treatment has been misused, how much treatment has been used. But if you say that acquired drug resistance globally has been reported for isoniazid maybe from 0 to 50%. And streptomycin resistance was reported in the tune of 0 to around 15 to 16%. If you see the Indian data, the ICMR was first to conduct the studies on drug resistance. It was reported in 1968 and 69, and they called about the primary drug resistance for primary line of drugs. Usually they are present in the tune of around 20%. And if you talk of specific drug resistance, say INH drug resistance, again it was reported in tune of 10 to 15%. Streptomycin drug resistance was reported again 5 to 10%. as far as acquired drug resistance has been reported up to 50% of the cases, and INH acquired drug resistance was reported from 15% to 60%. It ranged depending upon what type of population has been studied, but there has been isolated studies which are talking about such type of a drug resistance, and then streptomycin acquired type of drug resistance is again reported maybe around 15 to 20 to 30%. So, what I am trying to say that as you misuse the drug, chances of getting resistance to primary line of drugs, either mono or polydrug resistance, can be very high if patient has misused these drugs. Now, next few minutes we will talk about MDR and XDR TB. Now, if you see the global report 2015 WHO report, it talks that MDR TB globally, the primary type of MDR TB is present in around 3.3%, and acquired type of MDR TB is multiplied by 5 to 6 times in the tune of 20%. And these reports, based on report available from 153 countries, accounting for 95% of the world population and estimated TB cases. And it is estimated, this is all estimated figure, that around 4,80,000 cases of MDR were there in 2014. Unfortunately, China, India and Russian Federation accounts for more than half of the cases of MDR TB prevalent globally. Now, it has another estimate what people are talking, that somebody had whatever reported cases globally are there the MDR TB has been reported in about 3 lakhs patients in 2014. Again, in reported cases also, China, India and Russian Federation accounts for more than half of the cases. If we talk of the Indian data, it is again based on WHO Global Report 2015, and it is same like global figure. Primary drug resistance is around 2.2%, and acquired drug resistance is around 15%. And it has been estimated in India that around 99,000 patients every year emerged of MDR TB. Again, you see from the reported cases of TB from India, it is estimated that only 71,000 appeared in 2014. So, what I am trying to say that the MDR TB somehow may range from 70 to 90 to 1 lakh. So, average about 1 lakh patients of MDR TB arise every year in the country. Now, we have a lot of paper has come, we start talking about pre-XDR TB or XDR TB, even, and what is pre-XDR TB? Pre-XDR TB means before one becomes XDR TB, there is a pre-XDR. Pre-XDR TB is MDR TB and one drug resistance to either fluoroquinolones or second line injectables. When both are become drug resistant, then it called as XDR. So, before XDR, one can develop pre-XDR. Pre-XDR, especially the MDR with fluoroquinolone resistance, globally as well as in India, it is very common. About 20 to 30% of the MDR patients, they have been reported as pre-XDR TB, means MDR TB with fluoroquinolone resistance. You can understand how the fluoroquinolone have been misused. That is why this type of TB is rising. As far as XDR TB is concerned, as I have already defined, it is MDR TB plus resistance to one of the fluoroquinolone, and one of the second line injectables. It has already reported in 105 countries. At least one case has been reported globally since 2002. And 9.7% of the MDR TB are supposed to have XDR TB. It is estimated globally that around 25,000 of XDR TB cases emerge every year. From India, lot of reports by this time are available from India, which talks that XDR TB may be as prevalent as globally, that is ranging from 3% to 11%. And one of the study from India has shown that 24% of the ofloxacin resistance associated with MDR TB, that is pre-XDR TB. And so what I am trying to say, XDR TB is also, it is also reported from this country. Now, few reports have started coming, the emergence of total drug resistance, and especially from the Mumbai, but I said that still WHO has not defined drug resistant TB. Now, a word about drug resistance in extrapulmonary tuberculosis. Now, when we talk of a drug resistant extrapulmonary TB, as for science, the extrapulmonary TB, most of the sites, they are a paucibacillary tuberculosis. So, development of drug resistance in them is low as compared to pulmonary TB, but few reports are saying that drug resistant TB can also be present in extrapulmonary tuberculosis. I will not go into details of it, but few of the reports have really started saying, and especially extrapulmonary tuberculosis, if somebody is infected to resistant type of bacilli, he can have drug resistance even extrapulmonary tuberculosis. So, ladies and gentlemen, what you have seen that God has given the sensitive TB, but I used to say the march is going on from sensitive to mono or poly drug resistance, from mono and poly MDR TB, then XDR TB, then TDR TB, and finally you have seen patients are dying. Why in India 2.5 lakh patients are dying every year? Because possibly is the development of this march, development of drug resistance, and there the treatment is not possible for everyone to complete. So, there is a death has been reported. So, what I have seen, now when you see that there are so much of drug resistance, question comes to our mind that why this drug resistance? What are the causes? If I have to say in one line why there is a drug resistance, to my understanding, what I have understood in last 40 years, it is either the poor control or clinical practices. Either there is a problem in control program or there is a problem in day-to-day clinical practice by the private sector. So, let us examine one by one how everyone can contribute towards the development of drug resistant TB. When any patient develops a TB, he goes either into a private sector or into government sector. Let us start, and figure is roughly 50% goes to the private sector and 50% goes to the government sector. Now, as you know that TB management in the public sector, we have revised National TB Control Program, which is offering treatment to all types of tuberculosis. As you know, we have new patients, we have retreatment group, we have MDR group, we have XDR group. So, in India, globally and in India also, TB treatment is provided in revised National TB Control Program free of cost. We have by now in India at least 19 million TB patients have put on treatment. 3.4 million additional life has been saved, and more than 80,000 MDR TB and 3,000 XDR TB patients have been placed on treatment. So, today we can boast that India National TB Control Program, that is RNTCP, one of the largest TB control program of the world. But we have still longer way to go. Every third case is missed, still case notification stagnating, incidence decline too slow. Every sixth case continues to die. Over 50% of MDR TB cases are not diagnosed or treated properly. We don't know actually. The government is able to cater only about 50%. 50% how they are treated, we don't know exactly. So still we have very long way to go. Now let us, when I said that 50% of the patient is going to the private sector, when I say private sector, my definition is different. In India at least, everybody is a private sector. I know that in most of the states, the private practice is allowed, and so in the morning, the doctors working in the government sector, in the evening, when practice is allowed, they work in a private sector. So, the private sector is not only private sector, it's a government as well as the private doctors. Even private doctors, multiple type of private doctors in India, qualified, less qualified, unqualified. So, it's a very huge sector what I am trying to say. Let us examine by few slides how private sector treats tuberculosis. Now, the first study I always quote is a study done from Mumbai. Mr. Uplekar published in Tubercle in 1991 how the treatment of tuberculosis is done by the private general practitioners in city of Mumbai. And he interviewed 79 allopaths, 64 non-allopaths from Mumbai, and what was found in brief that 100 doctors from city of Mumbai prescribed more than 80 regimen. Possibly everyone is prescribing in own way. Then we did also a study which was published in the same journal in 2002, which was, and we have studied 449 doctors, their prescription habits, and we could find instead of 80, good news was 33 different regimens were prescribed. 62% of the doctors took weight, only 50% advised sputum smear for AB, 45% of the doctor did not practice current NTP or WHO recommended regimens, and worst part was that we have analyzed overall 75% of the doctors made one or another prescription error. But the good point from this study was that around 2/3 of the doctors used fixed dose combinations of 2 to 4 drugs. In Mumbai, they repeated the study after 20 years, and they again published in 2010 that TB management by private practitioners in Mumbai has anything changed in 2 decades. But I am sorry to share with you that in that study, that 6 of 106 responders wrote correct drug regimen. 106 doctors prescribed again 63 different regimens. There was tendency to overtreat with more drugs for longer duration, and 3 of the 106 respondents could write an appropriate prescription for MDR TB. So, you have seen that 20 years in a city like Mumbai, hardly anything has changed. That clearly indicates we need lot of CMEs, lot of education in undergraduate level, postgraduate level, at private sector level, so that they can prescribe a proper regimen. What is a systemic review was done by Dr. Satyanarayana, and it was published again in 2015, that what is the quality of tuberculosis care in India. And that says that there is only half of the health care provided aware of importance of suspecting TB in person with cough of more than 2 to 3 weeks. 2/3 knew using sputum smear exam for person with presumed TB. 1/3 of the providers aware of the correct regimen for new patients of TB. Only 1/3 of reported dots are supervised approach for the treatment support. And so finally, what this paper says that there is a suboptimal quality of TB care, particularly in private sector. So what I am trying to say, the private sector, which is very respected, people have a lot of faith in the private sector, even that, and even there are problems in that sector also. You have seen problems in the government sector. Now you are seeing problems in the private sector also. And MDR TB, as I said earlier, that 50% of the patients of MDR TB, they are outside the control program. How they are treated? Nobody knows in this country how it is treated. But we did a small study, which was multicentric study, comprised from Trivandrum, Lucknow, and Chennai, and what we could find that majority of the doctors, when they second line drugs are used, more than 87% of the patients, they have prescribed second line drug for more than 1 month. And you will be surprised to know that what are the second line drugs which are used in for when they suspect drug resistance. Most commonly used second line drugs are fluoroquinolones and kanamycin, followed by ethionamide. So what I am trying to say, if they are not used in a proper combination, drug resistance further grows, and this is why they are from monodrug resistance to polydrug resistance to MDR TB to XDR TB is progressing. Quality of drug, another cause for quality of drug. As many of you must be knowing that there has been many studies when they collected the drug from the Asian countries including India, that many of the FDCs which is very commonly prescribed are of poor quality or of poor bioavailability. So even quality of drug, even Government of India estimates that 12% of the drug tested are substandard. And we did again another study when I was in KGMU LUCKNOW, when what we did that in particular day of OPD, we just scanned all the prescriptions and which type of ATT doctors are prescribing. To our utter surprise, around 15% of the prescriptions we do not know that which company they are prescribing. So what I am trying to say, lot of prescription habits for poor quality drugs are also there. So that is why these MDR and XDR TB is coming up. So you have understood by now that drug resistance TB and especially the MDR and XDR TB, God has not given, it is a human made problem. And so it's a, what are the factors? You have already known, either there is inadequate national TB control program, inadequate treatment regimens you have seen, non-compliance of the treatment you have also seen, poor quality of drug may be there sometimes, addition of a single drug to the failing regimen, and most important when we talk of MDR and XDR TB, improper management of already existing resistant TB, use of too few drugs, drugs for a too short time, or relying on limited access to poor quality second line drugs. What I am trying to say, these are the main reasons why drug resistance develop, especially the MDR and XDR TB. So ladies and gentlemen, we have come to the end of presentation. What I am trying to say, that drug resistant TB is a common, it's a human made problem, and it must be prevented. And when we talk of prevention, we always say that new cases where chances of drug resistance is very low, in the tune of 2 to 3%, if they are treated properly with effective 4-drug regimen short course chemotherapy, patients are compliant, you can prevent most of the drug resistance. Thank you very much.